Welcome to ProScan Education Foundation's Pomerantz Mentor Series. And today we're going to continue our discussion on instability of the shoulder, which basically implies the phenomenon of dislocation or shoulder locking. There is another phenomenon called microinstability, where the shoulder feels like it might come out, but the patient never experiences overt dislocation, and they never experience on physical examination or trauma true locking. Now, I start out with something that's very counterintuitive. It is absolutely an inane and terribly annoying situation when you present a case to somebody and the history is instability, in other words, hypermobility. The shoulder's coming out of the joint, and yet you are presented with an image of somebody that has adhesive capsulitis, and in the history, it may say diminished range of motion. And yet when you look at this adhesive capsulitis, which consists of fibrous tissue or fibroinflammatory tissue that is just baking into the joint, and when you give contrast, it inflames. But there's no effusion, which is typical of adhesive capsulitis, and somebody interprets this as the signs of a prior capsular injury from a dislocation. That's crazy. Why is it crazy? Because people like this, with this appearance, have diminished range of motion. They have a frozen shoulder. So you have to take into account the historical information with the imaging information and not make nonsensical diagnoses. In other words, the clinical and the MR picture have to fit together. Otherwise, you're going down the wrong pathway. I mean, here's another example of our patient who was incorrectly diagnosed as having instability, even though the diagnosis is adhesive capsulitis. This is a contrast-enhanced MR. And everything you're seeing here, which produces the dry corona sign. Here's the corona right here. Here's the sun in the middle. It's a little bit like a solar eclipse. This is all enhancement around the capsule into the rotator interval, even infiltrating the subscapularis tendon. This is all part of the process of massive adhesive capsulitis. And on the right side, where no contrast is given, you're looking at a proton density fat suppression image. This is all still inflammatory tissue, but it's not fluid. It's not an effusion. The capsule is a little bit distended, but it is tightened up by all of this fibroinflammatory tissue, as opposed to the broad, floppy, stretched out capsule that you get in a dislocator. So this is a nice lead-in to the next subject, which is flicking the deck on your PACS system. And what do I mean by that? I mean that like you flick a deck of cards, you're going to flick through the images in the coronal plane and in the axial plane and make a proper, reasonable deduction. Let's take, for example, the coronal projection. There are a few rules about the coronal projection. We discussed these in prior vignettes, but they're worth reviewing. When you go from the front of the shoulder to the back of the shoulder, the clefts and fissures that you see in the upper quadrant of the shoulder in the labrum should begin to diminish or dissipate as you go more posteriorly. For instance, on the left-hand side, we are in a single posterior image, and we'll flick the deck in a moment in another plane, and yet this signal in the superior labrum is present, and there is a paralabral pseudocyst. It's not a true cyst because it's not epithelial line. So we know, because we're behind the takeoff of the biceps, we're in the posterior quadrant of the shoulder, where fissures and clefts should dissipate, that the mere presence of this cleft means it's abnormal. And then we look down inferiorly at another patient. And another rule of thumb in the coronal projection is any fissures or clefts inferiorly that are composed of capsule or hyaline cartilage should never go out the medial side. And a second tenet is they should never be associated with paralabral pseudocysts. Now, how do you tell that's a pseudocyst and not just some floppy capsule? Well, it's under pressure. It doesn't have the shape of the capsule, which is over here. One sees a knobby, expansile appearance with some septation. So the very fact that it's under pressure, and you can see a tail, this is the tail, going right through the inferior labrum, it should never be able to come all the way out medially, means that it's abnormal. let's turn to some additional golden rules. These are perhaps more apropos to the macro instability dislocating shoulder. The coronal rules, those usually come into play more when you're looking for superior or inferior labral tears that are related to lesser degrees of instability, minor trauma, slap lesions or superior labral tears anterior to posterior, or PAL lesions, posterior to anterior inferior labral tears, the so-called upside down slap lesion. So more minor trauma. Now we're going to go to the more major trauma where you see shoulder overt dislocations. And this is easier to assess axially. So here are some golden rules. When you go from top to bottom, the anterior labrum should not diminish in size. It should not get smaller. It should not become less hypointense. In other words, its signal should not disappear. It should not medialize. It should stay in a nice axis so that it looks like it's hugging the humeral head like a goblet and a tennis ball inside. It is more focally fissured or clefted superiorly. But as you move below the equator, those clefts, those interdigitations, those variations, those fissures, they should dissipate or completely go away. So let's flick the deck on our PAC system. We start out superiorly, and perhaps there's a signal in the superior labrum that's abnormal. Alternatively, that could be a fissure or some hyaline cartilage. We're not sure yet, but let's keep going. And yes, there is a small pseudocyst off to the side. As we keep going, the signal in the posterior labrum persists and is somewhat serpiginous. We're still not yet sure about this signal intensity because anterior and superior is where all the variation is going to be. So let's keep going. We're at the level of the coracoid. We're going to go down another one. We still have the very bottom of the coracoid, and yet the labrum is now not snug as a bug in a rug on the adjacent glenoid. There's a big hole here. You could drive a small Buick through there. Are we low enough? Well, maybe, maybe not. So let's keep going a little lower. But in the back, the posterior labrum is opposed. It's closed down. This is what we want to see anteriorly on the next slice. And do we see it? Absolutely not. Our space persists. There's a space between the labro-ligamentous complex and the glenoid. Well, let's take another slice down. The space still persists, but it's awfully ragged looking as well. It looks nothing like the smoother relationship of the posterior labrum. It's not as black as the posterior labrum. Two clear abnormalities that violate our golden rules. And still we go down further. The space persists. The bone is now truncated and remodeled, and there's an extra opacity or area of intermediate signal intensity anteriorly that represents part of the injured labro-ligamentous complex. Still, even further inferiorly, we're well below the equator into the axillary or inferior quadrant. The space is still present while the posterior labrum is properly opposed. And anteriorly, one can see the subscapularis insertion on the lesser tuberosity. In the sagittal projection, we'll often look at the phenomena of macro instability by quadrant or by clock. Typically, the lower numbers on the clock are anterior, the higher numbers on the clock are posterior. This is the site of the labro-ligamentous injury. So we might say that the injury begins just a little past 3 o'clock and continues on to 6 o'clock. But when we make that distinction, we always continue by addressing the location by quadrant. Because the clock face can be a little confusing to primary care physicians and some general orthopedic surgeons. So I'll say 3 to 6 o'clock or the anterior inferior quadrant of the left shoulder. Well, this concludes part 3 of the Pomerantz Mentor series on macro instability. The big takeaway message in this section was the evaluation in the axial projection from top to bottom of the anterior labrum, and how the transition of the labrum becomes more normal, more robust, more black, less variation, and fewer clefts, the more inferior you get in the anterior quadrant of the shoulder from top to bottom. In Part 4, we'll be talking about some additional terminology for macro instability, showing you classic Bankert's and classic Hill-Sachs lesions, which are part of the dislocation syndrome, and getting into some of the Bankert lesion wannabes or Bankert lesion equivalents. Look forward to seeing you on this next vignette. Thanks.